I want to thank Kathy, the Gildenhorn Institute and Sibley Hospital for allowing me to give this talk. It's a talk that I've given over the last few years, and I got to say it's a topic that's still evolving and has great interest from both the surgical aspect and the non-surgical aspect. We'll be talking about some of the current alternatives for the biologic treatment of osteoarthritis. At the end of this, there's going to be there's a spot on your screen for question and answers that you can write down the question, and I'll be happy to answer. First, a little bit about me. I've been in Washington, D.C. now for over 20 years. I'm an orthopedic surgeon specializing in sports medicine. My goal really throughout my career has been to try to maintain an active lifestyle for my patients. As a sports medicine surgeon, I focus primarily on the knee and the shoulder from an operative perspective, but really kind of manage the whole patient really from head to toe when it comes to their activity levels, both in the competitive athlete and for your kind of weekend warrior and just recreational athlete. A lot of my surgery, I do joint replacement, but a lot of my surgery is with the intent to prevent or to try to delay that outcome. And this talk's going to kind of look at not so much stem cells, but really, because I think that's a misnomer, but to what's called the Orthobiologics. And it's kind of a new treatment class that's out that actually it seems to have some promise based on some of the early, let's say, outcome studies that we have. When you look at osteoarthritis, it's a very prevalent problem. It's estimated that by 2030, 25% of our population will have some form of osteoarthritis in some joint. At present, its costs are over 1% of our GNP at $300 billion. When you look at the causes of osteoarthritis, it's multifactorial. Yes, it can be just age and the activities that, let's say, we put on our joints throughout the years, but an increased activity level and more exercise within the population has led to an increased incidence of this. Obesity, and believe it or not, prior surgery. And that I think a lot of folks who actually, let's say, end up with arthritis at some point had surgery, let's say, beforehand, secondary to some type of injury. And that's where this, this topic comes into play, in that I think if we can delay surgery on the short end, sometimes that benefits us more on the long end. A little bit about osteoarthritis, and I think when let's go over first what it is, and it's a breakdown of articular cartilage. Articular cartilage is the covering of our joints. If you look at the chicken bone, it's the blue on the chicken bone. It really has a very highly organized structure. It's only about 10%. You can see the cells on the slide to the right here. Only about 10% of it is really cellular, and the rest of it is a protein of both collagen and of what we call proteoglycans. And the organization of these structures within the cartilage actually gives it its load-bearing capacities and allows the joints to move freely and absorb stress. When you look at osteoarthritis, by definition, it's the enzymatic it's the destruction of articular cartilage by the enzymes or proteins that are within the joint. Again, its etiology or its cause is multifactorial. It can be trauma, can be aging. There can be a genetic component based on how we load our joints. If you're really bow-legged or knock-kneed, obviously you're distributing stress on your joints a little bit differently than, let's say, if your leg is really neutral. But when you look at osteoarthritis, it seems to disrupt the function of articular cartilage by breaking down that highly organized structure. At a microscopic level, what you see here on this slide is the breakdown of a nice smooth surface of articular cartilage. And at a microscopic level, this involves a change in the protein composition or a change in that organization, as well as an increase in water content within the joint that in some joints you can see as them being swollen. The fluid that normally makes up the joint has a function of lubricating it, and as these proteins break down the cartilage, they also break down that fluid, which disrupts how it works, and that has some interplay in terms of some of the different treatments biologically that we have to kind of, let's say, combat this. Treatment alternatives for osteoarthritis. are both conservative and surgical. Surgical can be anywhere from an arthroscopy where we're putting the camera in to an osteotomy where we realign the knee. Replacement's favored, and you'll see that's a pretty good form of treatment for some patients, but it's a big surgery. There are some biological alternatives that are more for, let's say, the minimally arthritic knee, not for the end-stage arthritic knee that we sometimes do. This talk's going to focus more on the conservative treatments. And when you look at the conservative management of osteoarthritis, you have medications that can be both what we call symptom modifying or can make you feel better, or disease modifying agents. And that refers to possibly some of the orthobiologics that we're going to talk to. This topic, I guess, if you look at it from the standpoint of a regenerative medicine component, I think if you really truly believe that this stuff does, let's say, regenerate the joint and kind of, let's say, restore cartilage, it's at the forefront of that, let's say, subspecialty of medicine. We're also going to spend a short time on what's called radiofrequency ablation, which is a newer technique that is, I got to say, let's say, utilized to decrease, probably not eliminate, but to decrease pain in some very specific circumstances that we'll talk about. The problem with osteoarthritis, well, if you look at it from a standpoint of successful treatment, joint replacement does work. But as I said, it's a very big surgery. And what you're doing is you're basically taking the biology that a higher power has given us, and you're resurfacing that with metal and plastic. And while that's good in the short term, just like the tires on your car, the metal and the plastic does not last forever. It works really well in the 65 and older population, where 92% of total knees that are done are still in place at 20 years. That sounds pretty good. And what that has done is it's basically decreased our indications. So now we're doing them on younger people. But what you can see is total knee replacement in the population under 40, only 87% are still in place at 10 years. So you go from 92 at 20 to 87 at 10. So really, the holy grail right now within this cartilage treatment, let's say, framework, is we need less invasive surgical alternatives as well as non-surgical alternatives to see if we can delay replacement as long as possible. The first treatment that I got to say that most of us use is a symptom modifying agent, and this is really Advil and Aleve, okay? They're very good anti-inflammatories, and really they do nothing to treat the arthritic process, but what they do is they help, because when taken consistently, not only do they decrease the pain, but they also decrease some of the swelling and some of the symptoms that are associated with osteoarthritis. The problem with these agents is that everybody can't take them, number one. And two, taken chronically, they can sometimes have some other side effects medically that aren't too pleasing in the form of gastrointestinal effects and hypertension. But I think as a first-line form of treatment, most orthopedists would agree that an anti-inflammatory has a place in the treatment of osteoarthritis. We'll now move on to some of the structure-modifying or disease-modifying agents. And this was the first one that really came to market, and it's been out about 20 years. And it's glucosamine and chondroitin sulfate. And basically what it is, glucosamine and chondroitin sulfate are two of the proteins that make up that highly organized cartilage surface. And if the composition in the arthritic knee of these products is decreased, the thought process was, well, why can't we just take a pill and that pill can just add to the protein makeup of the cartilage in your knee. Seems pretty simple. It's like a vitamin. It's what's called a nutraceutical. So these agents are not really, let's say, controlled by the FDA. There are many different, let's say, product lines that are out there, both generic and let's say more specific. But I got to say they're really all pretty similar in terms of their composition. When patients ask me whether or not these products work, I usually refer them to the study that was done at the NIH back in 2006, and it's called the GAIT trial. It was a very well-organized study where they took 1,600 patients and gave them glucosamine and chondroitin, gave them a placebo or a sugar pill, or gave them Celebrex, which is a common anti-inflammatory. They looked at these patients at 6 months, and what they found was that the anti-inflammatory did best. And then if you took all the patients and you actually compared glucosamine and chondroitin to both Celebrex and to the placebo, when looking at all the patients together, glucosamine and chondroitin did no better than the actual placebo or the sugar pill, which is a little bit humbling. But I think if you actually look at the study a little closer, you can see that patients who had more pervasive arthritic change actually did see some benefit. The important part, I think, of this study also was that established safety, that glucosamine and chondroitin, when taken, properly, really, it's like a vitamin. It really doesn't have a whole lot of side effects. And I think if you look at this, I'll usually use this for the younger patient who has a really hard problem. And I'll say, like a multivitamin, you may not see the effects tomorrow, but if this helps you over the next 10 or 15 years, it's worth it. If you look at the literature in whole on this product, I think what you can say is that there are inconsistent results that are found within the literature. It is safe, but many of the studies are inconsistent in follow-up and receive some financial support from those who are actually, let's say, supporting the product, which isn't good when you look at it from a standpoint of R&D. I think you also got to look at the placebo effect. Patients want to get better. And, sometimes even with a multivitamin, if you take a multivitamin this week and you say, I feel better, that may be the vitamin, but it may be your, let's say, mental aspect in terms of I'm doing something proactively to improve my health. Hyaluronic acid is another form of a disease-modifying agent. And what this is, like glucosamine and chondroitin, it's a protein that makes up the normal joint fluid. Okay, so it's within the cartilage, but it's also within the joint fluid. Normally, this fluid has a molecular weight of about 5 to 7 million units. It's produced by the chondrocytes, which are the cells within the cartilage itself, and also the synovium, which is the lining of the joint. When implemented, it's an injectable form where the chondroitin and the glucosamine were actually pills, where this is an injectable that one can add to the joint. In osteoarthritis, the enzymes that break down the cartilage also break down this fluid. And the thought process is that in the arthritic joint, the fluid does not have the viscosity. It lacks some of the biophysical properties that actually lubricate the joint. So this has been marketed early on as a lubricant, where we think it actually works in that fashion, but it also adds nutrients and it adds, let's say, a good biologic environment to the joint. There are many different forms of this out, and I think a lot of it is really predicated on their molecular weights. They're completely natural, 100%. They come from a rooster or they're genetically engineered. Okay, so there's nothing, let's say, there's nothing unnatural about these. Side effects are very minimal. Insurance covers it. They've been out for quite some time, and I think if you look at some of the early research, it's pretty impressive. What you see on the left side here is an osteoarthritic joint. The joint on the right over here is actually a joint that's been treated with hyaluronic acid 8 months later. So there is some scientific evidence that not only can this, let's say, hasten the breakdown, but that it also promotes for possibly cartilaginous repair. It's an injection that can be done for anywhere between 1 and 3 injections. When it came out, it used to be 5 injections, and it went down to 3 injections, and now it's in a 1 injection prep. Insurance will usually let you do this every 6 months. It's 100% natural. I think for those really, I tell patients, I think it works about 60% of the time. If you look at some of the studies that are out there, I think the studies would tell you the less the arthritis, the more efficacious this is. I mean, if you have an end-stage arthritic joint that, let's say, is bone on bone, the chances of success probably are less, okay, than if you have, let's say, a minimally affected joint with symptoms. If you look at all the studies and kind of combine them together, I think what you can say is that HA works to decrease pain and increase activity, which is really what we're looking at. It decreases swelling in the leg. In the joint or the knee. It does have large placebo effects. So like the chondroitin and the glucosamine, patients sometimes, feel better, mentally because they're doing something proactively. If you look at this, and this is the question that you get a lot from patients, is how does this compare to a corticosteroid that you inject in the knee? And it seems to be better over the long term. Corticosteroids work in terms of modifying the symptoms. There's a limited number that we can do, so I'll usually use this as an augment to the corticosteroid. It has no harmful effects on the joint. Insurance will usually mandate what product you use, but they'll usually cover it. Medicare covers it. In conclusion on the hyaluronic acid, I think evidence in the literature shows that it demonstrates short-term benefits in mild to moderate arthritic change. I think cost in and of itself, prevents this to be, let's being your first line course of treatment, and at 60%, let's say, improvement, I don't see that as a great first line approach, but it probably is my second line approach to the arthritic joint. It's used in other applications in terms of the hip, shoulder, and ankle, and they seem to work comparable to the knee. Last thing we'll talk about from the standpoint of the orthobiologics are blood, and we'll talk about fat. And when you talk about orthobiologic therapy, I think you're talking about the regenerative component or the regenerative potential of these treatments. It's used for both arthritis, but it's also used for muscle and tendon injuries. We're going to focus on the arthritic component, but I'll go over a little bit of the muscle and tendon component as well. This class of treatment uses the body's capacity for healing to improve joint function. So I think when you look at this critically, and depending on what your viewpoint is, you can look at this as the fountain of youth, and that it's going to, let's say, restore your joint to when you were 18. Others look at this and think, well, maybe it's more along a scam, okay? And that there really are not that many studies that are out there right now that actually, let's say, are scientifically well done, controlled studies that actually look at this and compare it to some of the treatments that we've looked at. I look at this as an alternative route and as an evolving route in terms of how to treat my patients. This came to the orthopedic, let's say, theater, probably now about 15 years ago, where Hines Ward, who was a player with the Pittsburgh Steelers, injured his knee a few weeks before the Super Bowl. And he had what was called PRP, which is plasma-rich platelets, which is probably the most simplistic of the orthobiologics. And that treatment actually helped him play in a game 2 or 3 weeks after originally injuring his knee. So there was a lot of, let's say, enthusiasm for this treatment. Normally that injury would take, let's say, 4 to 6 weeks. He was able to get back at 2. But it's a treatment that has really gained popularity in the medical field. Back in 2009, $45 million were spent on this. This year, $265 million. It's got applications outside of orthopedics, in that oral surgery, plastic surgery, vascular surgery, and hair transplantation even this has been utilized in some format. We'll talk about the orthopedic applications. Really, the definition of plasma-rich platelets is basically it's taking one's blood, using a centrifuge to spin it down, and actually concentrate the platelets that you'll see have good healing potential in combination with some of the growth factors and secretory proteins that, let's say, inhibit the breakdown and promote healing at a cellular level. So it sounds really good. The technique's fairly simple. It can be done in the office, where blood is taken, it's put into a centrifuge and then spun around, and then it can be injected at the time of that visit. Usually takes about 20 to 30 minutes, the whole process. Platelets are concentrated within the PRP because the platelets have these small, what we call alpha granules that have a lot of these growth factors that, as previously stated, let's say have a positive regenerative effect, if you will, at a cellular level. In many medical arenas. From an orthopedic application, it's used for arthritis, but it's also used for tennis elbow, golfer's elbow. It's used for plantar fasciitis. I mean, you can see we've used this with varying, let's say, degrees of success in a lot of different areas. And that makes sometimes interpretation of the literature somewhat harder. The PRP that's used for the golfer's elbow is different than the PRP that we use in, well, let's say, for an arthritic knee. As this treatment has evolved, so has the research that's gone into it. And I think we are getting better in terms of kind of, let's say, delineating what problems seem to kind of, it works pretty well in, and other ones where it maybe doesn't have that healing benefit. But I think the idea with all these treatments is to incite a healing process or limit the inflammation in a painful area. When you look at cartilage, what PRP does within the joint is it incites or it improves, let's say, the healing capability, okay, of some of the proteoglycans and some of the things that are broken down in arthritis. It also inhibits or it slows down the direct effect of these enzymes on breaking down the cartilage itself. So at least at a cellular level, it has been shown to have to be a potential treatment for osteoarthritis, which is exciting. When you look at cortisone, it really doesn't have that. HA, we think probably, let's say, keeps the joint at a certain level, but there isn't, let's say, quite that data to say that it actually is going to heal the whole joint itself. It may prevent it from decreasing. But here you may have, something, or I think we're onto something that may actually have a healing potential in reversing that process. Leukocyte-rich PRP is PRP with a high white blood cell count, and that's really good for soft tissue injuries. When you look at arthritis, we use what's called leukocyte poor, or PRP that has very few white blood cells in it. So we have different systems that can separate different components of one's blood, and that has shown different levels of efficacy depending on what you're injecting. In Europe, this is actually favored over hyaluronic acid. Okay, if you go to the doctor in a small Italian town, he can have a centrifuge in his back office and he can spin that blood down and inject it back in. So that really, I gotta say, is probably the first or second approach that's used kind of worldwide, where if you actually look at what's going on from the standpoint of PRP in America, it's used as probably a second or a third line. The problem with this right now, from my standpoint, is that insurance really doesn't cover it. And I got to just say, the cost can be anywhere between $200 and let's say $1,000, depending on what you're injecting for what. We also need more studies kind of to correlate this product with, let's say, rehab regimens, number, frequency, can it be redone? And then we're going to go now to the stem cell component. And if you look at stem cells and you look at what they do, actually, I think there's a big misnomer in the orthopedic, let's say, in the orthopedic component of medicine, in that, stem cells in their pure form are really not approved right now in 2020 for musculoskeletal application. Okay, this is, to be a stem cell, the cell has to have the capacity to differentiate into multiple types of cells, and it needs to be able to self-replicate and kind of reproduce in and of itself. There are two types. There's embryonic, which aren't used in the orthopedic application, which actually come from the fetus, okay? And that's where there's ethical, and there's, let's say, there's a lot of scientific scrutiny. And then there's mesenchymal stem cells, which we get from our own body, and we can manipulate those gently and re-inject those with the hope that they're either going to heal diseased tissue or, at the very least, inhibit the inflammatory response that's associated with the inflamed or the arthritic joint. So again, these we would hope to work, let's say, through the regenerative component, but that really hasn't been proved in 2020. Okay, we know that when they do work, they decrease some of the inflammation, but whether or not they're actually, let's say, forming new cells is still a matter of debate. Mesenchymal stem cells in the adult population include bone marrow, fat or adipose tissue, and then we can use the umbilical cord or amniotic fluid, okay, not the placenta, okay, but the actual, the amniotic fluid itself, that has been used in this arena for a potential, let's say, cure for the arthritic joint. Bone marrow aspiration, this can be done in the office. It's done with a local anesthetic, and basically what's done is you put a trocar into the area of the pelvis, you aspirate the actual bone marrow, and with that, you have the quote-unquote stem cell. Age is dependent, meaning the younger patients will have let's say, a greater concentration of these cells than the older patient. So, when you look at what you use, if you're going to try to, let's say, utilize this is best done in the younger patient. There are some companies out now that are looking at banking these cells for the possibility for future use once the applications are a little bit more well-defined. Adipose cells, on the other hand, are age independent, meaning the cells from a 60-year-old are the same as from the cells of a 20-year-old. There's a company out, Lipogems, that has a proprietary, let's say, technique of obtaining fat cells, almost like the plastic surgeon does, and spitting them down and then re-injecting them in the joint. So basically, there's a way that we can get some of these fat cells out, proprietary technique that actually separates them from some of the other components, and then you get basically a syringe of these lipogems, which has let's say, a significant reparative or regenerative capacity. Amniotic or placental tissue, it makes sense. If it's good for the fetus, it actually is very rich with growth factors, cytokines, a lot of the good things that we use, okay, or that we need for a healthy joint. So for patients who are on anti-inflammatories, where you really can't, let's say, either take bone marrow or take or take fat, I'm sorry, not anti-inflammatories, but anticoagulants, because they have a propensity to bleed, this is a reasonable alternative. Unlike the first two, which are taking one's own cells and manipulating them to some degree and injecting them back in, this obviously is done from an outside source and can have some ethical implications, but is not what we call an embryonic stem cell because it's not the fetus itself. The FDA's position on this is really pretty stringent. I got to say, while HA and while PRP, they tend to be involved and they tend to, let's say monitor what's going on. There are regulations that what can be used actually in the true stem cell community. Bone marrow and blood stem cells are presently being used really for cancer and for disorders of the blood and the immune system. We worry about infection. We worry about, let's say, pushing this too far to the point where it creates scientific as well as ethical problems. Conclusion on stem cells is that I think it does have a huge potential for inhibiting the inflammatory process of osteoarthritis. It can be done in isolation in the office, or it can be done in conjunction with surgery. It's been proven safety by our outcome studies, okay? I think if you look at everything that's been talked in this has been proven to be safe, okay? The cons are really, are they truly regenerative? And I gotta say, we've made some progress in that, and I think we're, each year we seem like we're getting a little bit more data and a little bit more specific in terms of where this may fall. But, still, if you were to ask me, is this truly degenerative? I would tell you, I think it can decrease inflammation, it can decrease pain, it may have that benefit effect. The number of treatments, the rehab that actually follows, still, I think it varies from clinician to clinician. The cost of this can be prohibitive. Insurance doesn't cover it. It's not FDA approved as of yet. Hopefully, as we get better research studies, that too will fall into check as time goes on. Because if we can avoid replacement in the end, I think there is a huge gross savings, for the field of medicine, if you will, with the added benefit that even a total knee is not a normal knee. It's a knee that shouldn't hurt, and it's a knee that works pretty well, but it's not normal. Lastly, we'll talk quickly about radiofrequency ablation. And I gotta say, for patients who've had a total knee where they're still in pain, patients with low-grade arthritis, or patients who are non-surgical candidates, and let's say have tried and maybe failed some of the things that we've talked about, this is a technique that was taken from spine surgery, and basically the nerves that surround the joint, surround the knee joint, can be ablated with a laser. and with that, some of the pain that is actually, let's say, that is propagated from those nerves can be ablated and can be eliminated. It's not a panacea, meaning if the patient has on a scale of 1 to 10 has a pain of a 10, I'll usually say to patients it can make you 30 or 40% better. The upside is that really there's not a huge, let's say, detriment to this, okay? And that there's no morbidity in the motor function. These are all sensory nerves. They do make you a little numb around the knee, but numbness is in some respects sometimes better for pain in some of these complicated situations. Studies seem to demonstrate a mild to moderate decrease in pain at 4 to 12 weeks. And basically what's done is under fluoroscopy or under x-ray, these little probes are put in. You're awake when this is done. And then we use a cool laser to kind of ablate and to, let's say, coagulate these nerves, if you will. Biologic procedures from a surgical perspective. The problem now in 2020 is that a lot of, and this is a big part of my practice, but this really isn't for the arthritic knee, okay? If you look at this knee here, what you see is one small little defect. That's a patient that we could try to regrow cartilage in that area using some of the cellular-based techniques that we do surgically. The arthritic knee, you can see, is much more broken down, and some of these let's say, surgical interventions don't work well when there's multiple areas that are involved. And in those cases, basically what you do is you take out those areas and you replace it with metal and plastic. Conclusion, I think that we're seeking alternatives for joint replacement. Orthobiologics are an evolving subspecialty within orthopedics. I think it's here to stay, okay? They've been here for 5 to 10 years, and I gotta say, each and every year, it seems like we're getting a little bit more, let's say, closely to some of the, answers in terms of how does it work, what indications, and that should continue with more R&D. I think in 2020, it may not be regenerative in the way that we're applying it right now, but it does seem to reduce some of the inflammation within the joint and the pain that's associated with it. I tell patients in that capacity, it works as a natural anti-inflammatory. Again, I think here, patients always ask, why do I get arthritis? And sometimes we don't have the answer why, but I think in treating it, basically what we're really trying to do is, I think if you emphasize both the function of your patient and pain relief, I think that's a happy patient in the end. We don't have all the answers in terms of why, but at times I think sometimes the idea should be to keep things moving in a forward direction. I'd be happy to answer any questions that you guys have now. There's a Q&A component within the program that Kathy gave you. My office we have an office up in Chevy Chase. We have an office at Sibley Hospital and one downtown, where I'd be happy to talk about these alternatives as they, let's say, as they apply to your personal situation.